Desmond, are you with us?
Hi, can you hear me?
Yay! Yes, we can. Thank you.
Wonderful. Okay.
Okay.
Sorry, everyone, for being disconnected on Teams. We're having some challenges, but here we are. But I am so elated to welcome Dr. Ehi Nosakhare. Dr. Nosakhare is a data science manager at Microsoft's New England Research and Development Center, the NERD Center. She leads a team that designs, develops, and implements machine learning solutions and application projects across Microsoft's products and services. Prior to Microsoft, she completed a PhD in electrical engineering and computer science from MIT. Her dissertation focused on developing interpretable latent variable models and variational inference methods and applying them to mental health and well-being. Ehi got her SM in EECS from MIT and graduated with a bachelor's in science and electrical engineering, summa cum laude, from Howard University in Washington, D.C. She is the recipient of a Best Paper Award at the ML for Healthcare workshop at Neuro IPS. Her work has been published in ACM SIG KDD conference and IEEE Transactions in Effective Computing and ACM Transactions on Computing for Healthcare. She is very passionate about using ML to solve real-world problems and studying the ethical implications of ML and AI. In her spare time, she enjoys reading and relearning to play the cello. So without further ado, Ehi, thank you.
Hi, everyone. It's my pleasure to be here today. Afternoon for me, probably morning for you. I'll be talking about giving an overview on artificial intelligence, mental health, and Black communities, and really just highlighting how societal biases play into some of the technologies that we are creating and providing some ideas on how we can mitigate for it. And I'm really looking forward to the discussion later today. So I'll be leaving some of the gaps and the opportunities and implications for this discussion, so we can talk a little bit more about that. So we all know that there is a growing challenge, right? Straight to the point, we know that mental health issues are widespread and they are common. 1 in 4 people will be affected by mental disorder at some point in their lives. The WHO has estimated that about 264 million people are currently affected by depression worldwide, and that has made depression a leading cause of disability. And we know that the US population is about 350 million, so that's a lot of people. And we've seen that only 30% of African American or Black people with mental health conditions receive treatment each year. This is compared to about 43% of the average US population or 48% of white population. So it is poor across the board, but people of color are disproportionately affected. And yesterday we saw a lot of the disparities that exist that contribute to these outcomes that we're seeing. And these statistics are, even after you control for socioeconomic status and other demographic variables, you still see the disparities in access to care. At the same time, we're also seeing an increase in the use of personal health-related apps and sensors that help to monitor health and wellness outside of clinical settings. And these devices are better able to characterize environmental and lifestyle factors that contribute to mental health outcomes. And so on one hand, you're seeing the burden of mental health illness, and the other hand, you're seeing the rise of the data availability. This just, is a perfect storm for an increase in the study and exploration of how artificial intelligence can help solve Americans' impending mental health crisis. So AI or machine learning is increasingly being used in everyday lives, and mental health is by no means excluded from it. And so really what I would like to talk about is what are some of the ways that AI systems can help, really briefly, also some of the class of AI technologies that are currently being used. And then I would go into data sources that I use for the studies, as well as I'll break down, the way I see the 3 different kinds of biases that can influence these systems, and I would illustrate how to mitigate or see some of these biases using my work and the work of a former colleague at MIT. So going forward, while I was surveying the literature for this talk, I sort of broke down 4 ways in which people talk about how AI systems can help. One is to assist clinicians, to improve, to increase, and to recommend. The idea of assisting clinicians is to enable them or to assist them in making faster and accurate diagnoses. Also to do remote monitoring of symptoms and to help alert them when changes occur in between appointments, right? So that they can handle this knowledge and include this knowledge in the treatment plans that they have for their patients. AI systems are also being developed to infer when to intervene and raise alerts for people who are in need. Another way to improve, right, to improve access to mental health services, we're seeing that it's not always, we talked a lot on Tuesday about how there are some hard to reach areas, and people are starting to see how we can use AI to step in and fill in these gaps. And one that I'm particularly excited about is like, how do you use it to understand and to improve our understanding of mental health behaviors, or to behaviors that contribute to increase or decline in mental health. Another way is to increase engagement with therapeutics or adherence to the therapies that have been prescribed to individuals. And another class of, studies you would see is how do you recommend personalized interventions, healthy behaviors, or match people with appropriate therapists, or find peer support groups for individuals who need it. So these are some of the ways. I mean, this is by no means exhaustive, but I was able to distill it into like this 4 broad research topics. That said, as a result of that, we're also seeing, the technologies being developed across these 4 broad areas. They are the behavioral intervention technologies, which I think most of us here are familiar with. We also have mobile apps and wearable devices that are being infused with AI for symptom monitoring and health risk assessments, and these are becoming a lot more popular. We also have computerized treatments that have been recommended to individuals, as well as platforms for peer and community support. And so these are the broad classes that we're seeing emerging. By no means exhaustive. There's definitely like the virtual reality that Dr. Kirkburn talked about. Also some other AI systems like reinforcement technologies that are being used as well. But in terms of like machine learning, this is sort of the technologies that are being created. There are different kinds of data sources that are being fed into these algorithms, or that they're being used by these algorithms. One, which is becoming increasingly popular because of like mobile devices and trackers and apps and all of that, is sensors. So there are a lot of wearables. You have mobile phones, audio data for like speech therapy. We also have text, so social media, Twitter, SMS messages, clinical notes, so site notes. These are really unstructured data that are usually collected in their raw form and further distilled into ways that the models and the algorithms can use. And we also have structured data. So these are the health assessment questionnaires that you have, or health records that we get for medical records in the hospitals. And, the multimodal technology interactions, right? You're increasingly seeing people interacting with robots or human or virtual agent interactions, and data is being collected about what these interactions are and how they can improve on, build on, how they help people who may be struggling with mental health issues across the spectrum. And so because machine learning is data powered, bias can be encoded in 3 different ways. And I like to think of it as selection bias, which is in the training data that is used, or human bias, which is within the data itself, right? This is sort of capturing our collective biases as humans and in the society. And then also in the modeling choices, algorithmic bias. AI is by no means neutral. And I'll be talking a little bit more, I'll be illustrating a little bit more of this later on. It's important to note, however, that these biases are not mutually exclusive, right? And so it's not that if you have selective bias, you wouldn't have human bias, right? And this is part of the reason why it's kind of hard to tease them apart. You can't really say, oh, this is selection bias. It's not all the time that you'd be able to put either of these things in distinct buckets. But in the following slides, I'll try my best to highlight some of the harm that selection bias brings using a study that I did at MIT. And I will show a case study that was published in the American Medical Journal of Ethics by some MIT researchers to highlight, sort of how algorithmic bias can show up. And after this, I would also talk about some of the ways we can mitigate for these things and some of the gaps or the opportunities that I see. So selection bias, I like to say it occurs when there's a systemic difference between the characteristics of people who are selected for the study and people who are not. And this primarily shows up in AI or in machine learning systems or technology when there's underrepresentation in data. So there was this study that I came across earlier in the year. It was a study that was done by some researchers in the UK and in Australia. And at the time, they ran what was the largest longitudinal study using multimodal data for mobile devices. They had over 40,000 people over the course of 3 years download this app from the Android store. And they selected about 18,000 people to train deep neural network models for a prediction task. And what they were trying to predict was how they could, one, infer routine, and then also predict self-reported mood of individuals. And the data that was collected included surveys, call logs, text messages, and actigraphy data. Ultimately, there were out of the 40,000 people that downloaded the app, about 18,000 people were selected in the study. And so they published, or part of what they talked about was the demographic breakdown of the participants in the study. And this is the breakdown of the racial ethnicities that were represented. And if you are by any means curious about what the makeup of the African American or Black people are in this study, it is the red rectangle. I was about to say triangle one morning. It is the red rectangle that is currently highlighted. I mean, they didn't even release like the actual quantitative proportions, but it's very obvious that there weren't that many Black people represented in this study. And this is sadly not atypical of the data sets currently used to develop machine learning technology, including the data sets I used while I was in graduate school. Dr. Kirkman said that most of the psychology that we know right now is based on white male college students, and this is not an exaggeration, end quote. It is true. It is not an exaggeration. A lot of the work that we are doing in building these technologies really are not as representative as you would like them to be. This is primarily, in my opinion, an issue of study design, planning, and practice, and we should be putting in a lot of effort to ensure that we are incorporating user-centered design processes as we gather these data sets. Part of the problem that we're facing is that some of the studies do not even report race demographics in their data sets. So it's hard to even tell what the makeup is of the data that are used to develop these technologies. There is also some kind of harmful feedback loop, right? Where this exists when the existing disparities in the system, we're seeing that African Americans are disproportionately affected by access to care. And so these disparities lead to underrepresentation in the data sets that we collect. And then, it leads to that, we see that emphasized in selection bias in our algorithms. And of course, as technology is being developed, people are disenfranchised and left out of that process. And it further widens the disparity that we are seeing. And this is a huge problem because we know that AI or ML for mental health especially is not a one-size-fits-all approach. And therefore representation matters. And so if we want these approaches to be a lot more effective, we need to make sure that we are very careful about the makeup of our data sets. Next, I'll talk about very briefly about one of the studies I did at MIT that sort of illustrates why personalization matters. So in graduate school, my group ran the Snapshot study, which seeks to measure sleep, networks, affect, performance, stress, and health using objective techniques. And personally, for me, I had a very huge focus on using interpretable or explainable models. And some of the questions that we tried to answer was how can we predict the future mood or stress of students in our study? And given that we can predict this future mood, stress, or health of students, how can we tease apart this group of modifiable behaviors that contribute to the well-being. And then how can we use this knowledge to provide evidence-based recommendations to individuals that are seeking to improve their well-being? I will be talking about just the first part of this work that I did, which was predicting future mood, stress, or health. And I would use this to illustrate why we need to mitigate for selection bias in our development in our experiments as we build ML technologies. So briefly about the data overview, it was collected from college students in an observational study with informed consent and compensation. The students were monitored continuously for 30 days. And we had a variety of data. So anything with data sources, so it was multimodal data. So we looked at location patterns where we modeled using the Gaussian mixture model. We also used smartphone logs, so we didn't have any content, but we knew timestamps and the frequency of missed calls, calls that were received, calls that were outgoing, as well as SMS, and how often they used their screen. And then also the weather. We're in the New England area, and weather is a huge part of how you feel. It's currently like cloudy and gloomy and rainy outside right now. We also looked at physiology, so things like accelerometer data, skin temperature, electrodermal activity, which sometimes is a proxy for stress after processing. And we also looked at behavioral surveys, so self-reported stress and health and mood on a scale of 0 to 100 is what we used as our ground truth labels. And we also collected information about whether they exercise, consumed caffeine, alcohol, social interactions, and things like that. There were our predictive modeling task, we employed a technique called multitask learning, which rests on the premise that individually, when you train data sets or when you train models on data sets in standalone, you don't really perform as well. But when you are able to write techniques where you can share the information you're getting across the population or the groups of people in your data set, you get better accuracies. But what we showed with this study was while multitask learning was good, the sharing of information was good, what was even better was if you were further personalizing for each user that you were seeing. So there were two approaches we did. One was the well-being as a task, which was the multitask learning. So we're trying to predict future mood as a task, future stress as a task, future health as a task, while sharing information across those three tasks. And then we also looked at users, right? So for this particular user, can we predict their future mood, stress, health, and and so on and so forth. So those were some of the two approaches. So well-being as task and users as task. And the way we did it is we looked at features for a day, and there was a prediction gap of about 20 hours, and then we tried to predict this feature 8 p.m. the following day, what your mood, health, or stress, what we felt it was going to be based on the features that we had collected from the data set. And the reason that we had this prediction gap was because we felt like, and at the time, a lot of people were actually doing this, but we felt that it was important to give people an opportunity to adjust, right? So if I tell you this is how you're going to be feeling tomorrow evening, then you have time to actually maybe take some steps and to adjust that. Next, I will sort of cut the chase of the technicalities of the model itself, which, I can talk in the question and answer session. But what we saw with the results in terms of these two approaches was that when you looked at single task learning, right? So you didn't transfer any information, you didn't share any statistical strength. What you have is the blue, smaller, the first bars, right? And it wasn't really did that well. We really got results around 58, 59% accuracy. And then for mood, stress, and health. And then when you included multitask well-being, so now you were trying to learn the health or the self-reported health, self-reported mood, or self-reported stress of the individuals as this task while sharing across. But you were still looking at as individuals as a group, right? You got a little bit of a jump in mood. You actually lost accuracy in stress, and health, self-reported health didn't quite have any move. However, when you personalize to users, right? When you start to look at users as individuals, and now this method, obviously you can't build machine learning models per user. There were some nuances in terms of the way it created clusters. When you added that extra bit of personalization, there was a huge jump in accuracy. And at the time when the study was published, I think in 2000, 17 or 18, this was state of the art in terms of like this kind of work. So there was this huge gap in personalization, and not just accuracy. We see the same in area under the curve. And so personalization really does matter. So I'll skip this for time. And then, so one thing that I wanted to highlight was that even in a study of users where it wasn't quite, it wasn't a diverse group of students that were used, the models did show that personalization is important, right? And so selection bias creates a lot of harm because these technologies will not be able to learn patterns specific to individuals or groups of individuals who are not even represented in this community. And so machine learning is definitely not a one-size-fits-all approach. And as we're seeing that the more and more we personalize technologies to users, the more and more we're getting higher or better accuracies. This, really drives home the point for the need for representation and the mitigation of selection bias in the studies that we are doing. I'll move on to human bias. And this is really just some of the ways that our own, our own biases as individuals can get into the process. And this is primarily because mental health data can be subjective. As opposed to maybe if you're trying to look at cardiovascular disease, right, you would have certain quantitative regions where you're saying, oh, if your heart rate is between this or this value, you are in the danger zone, or if your blood sugar level is between this or this, there are quantitative measures, not the same for mental health. And especially, you can't even generalize like that because people are different, like we just saw. And there's a lot of reliance on clinical notes, and these are unstructured text that are used in patient assessment and treatment. And because of this, they are very expressive, they are subjective, and it also has a strong potential for bias. Another thing that I really struggled with when I worked with this was that self-reports or assessments are often the gold standard. So how you told me you felt about yourself was what, I took as is, right? And so it was really hard, how do you calibrate across users? And a lot of the biases get into this process based on this kind of assessments or, self-reports. Social media. There are a lot of technologies out there that use data from social media. So Twitter, Reddit threads. And if human biases in these situations are not mitigated for, it is a problem because there's an absence of clinically validated signals. And so researchers often develop proxies, often without the input of the individuals, right? And so you would say, oh, if the smiley is there, or if there this combination of words, these are probably what we think represents a depressive state. And so this could be an issue. But another even bigger issue is that it risks including only people who are aware of their decline in mental health and who are open to talk about it, right? Because it's only if I go to Twitter and say, oh, I am depressed, or I feel this certain way today, that you actually capture my feelings. So in some way there is, again, you see the selection bias coming in here, but then there's also this human bias where it's only capturing people who are sort of open to talk about their mental issues. And that the proxies that we're developing to assess this data, also includes some of our own biases and add that into the process. Next, I'll talk about algorithmic bias and sort of how it can show up. This was work done by some researchers at MIT, and algorithmic bias in general occurs when an ML model is trained on a given data set, and it produces results that may be completely unintended by the model creators, right? And this is because algorithms would almost always optimize for the majority class because that makes the most sense for it to boost its accuracy. And biases are often amplified through feedback loops, right? You penalize algorithms for losses, and so if we minimize the loss in the majority class, that's our best chance of getting higher accuracies. And so a lot of all these classes that are not represented are sort of, they suffer for this. So this was submitted to the American Medical Association Journal of Ethics. And what they did here was that they looked at psychiatric notes from the mimic data. They looked at over 4,000 notes from about 3,000 patients between 2011 and 2015, and they used this to try to predict 30-day psychiatric readmission rates. So how can we tell who comes back in 30 days? And this is a representation of the data set that they used. We have about 3,000 people who identified as white, about 430 people who identified as Black with very similar admission rates, and the rest Asian, Hispanics, and other people, or people who didn't have any demographic reported were below in their readmission rates, and then also less represented in the data when compared to the people who identified as white. So they try to use, it's called like a latent replay allocation, which is a topic modeling. So think of it as text summarization. So they're trying to understand what the themes that run broadly through these notes, right? So you summarize, like for each clinical note is like a document, and then you want to see, comparing all of the 4,000 documents, what are the topics that were represented? And this method is pretty interpretable because the topic ends up being just the distribution of words. And so they identified 50 topics that were common. And by the time they looked at the distribution of the words in each of those topics, you could tell that, oh, this is a depression topic, this is a bipolar disease topic, this is an anxiety topic. And then the next thing the authors did was they tried to see how the topics were represented along the racial demographics, right? And they saw that there was a prevalence of anxiety and chronic pain topics in the individuals that identified as white, while there was a prevalence of psychosis in the individuals that identified as Black and Hispanics and Asians. And so they highlighted how the clinical notes were reflecting the known disparities in the patient population. We have seen and we've heard about how, for this, while presenting the same set of symptoms, oftentimes Black people are diagnosed with higher mental disorders when compared to whites. And so the issue is when this sort of biased data is fed into the algorithm, you start to observe a difference in error rates. So what they did now was they used these topics, which were highly biased, to try to predict readmission rates. And even though these errors are not statistically significant, you can see that the Black population had one of the highest errors in this particular study, which goes to show how a lot of all these biases and disparities end up, and here you have, they were not represented. You have selection bias, you had human bias in the clinical notes, and now you have algorithmic bias, and this led to Black population having a higher error rate. And so it's really interesting to just see some of how these things happen and how they work hand in hand, and how you really cannot tease apart like these biases oftentimes. But what is important to note is, and I'll hint at this a little later, but like because these models were interpretable, we're able to like actually go in and understand what is happening. But sadly, a lot of the technologies that are being created now are not interpretable. And there's this trade-off between interpretability, explainability, and accuracy. So to summarize, sort of how these biases show up, we do know that algorithmic bias or selection bias or human bias have shown up in other spaces, right? And not just in mental health. They talked about like criminal police and criminal justice reform. We've seen it in recruiting. We've seen it in, mortgage or finance industry. But it's particularly very sensitive in the mental health community because this is very personal for a lot of people, and it's still very much stigmatized. And so as we go ahead creating these technologies, we need to be very careful about what we're creating and making sure that we are mitigating for biases in whichever form they show up, whether it's selection, human, or algorithmic. Next, I'll talk briefly about some of the gaps and opportunities that I have seen. And a lot of a lot of the work I now do at Microsoft is building technologies for explainability or interpretability. And I'll talk a little bit, I'll highlight that in subsequent points. But first, data sets. This is by far, I feel like, is the biggest opportunity. Making sure that we have data sets that are representative and having it out there, giving voices to those people who are actually on the ground doing the work, as opposed to, it's very easy, and I hope I don't get into trouble for this, but it's very easy to just keep funding our own institutions to do this work, right? But we do really need to step out of our network and make sure we are funding those researchers who are in these communities that are affected, who are bringing out the data sets in these communities, because that is really the only way, especially as machine learning is concerned, one of the only ways that we can level the playing field, right? If people are not as represented in the data sets, the technologies that we're going to be creating using those data sets are not going to be for them. So this is by far, I think, for me, one of the biggest takeaways that I have over the course of just really trying to dig into this. Another really huge opportunity for me is we can really use technology to advance our understanding of mental health in Black communities. When we have the data sets, this would actually lead us to be able to now create technologies that can contribute to the knowledge, right? We can't change everything that has happened in the past, but going forward, can we create technologies that advance the understanding of these communities as opposed to relying on data sets or technologies that have not that have not used data that are pretty representative? This one is huge, right? We need multidisciplinary teams. I'm a machine learning scientist. I am not a design expert, right? And so I should be working with people who have user-centered design training in order to design the studies, right, where we collect data, whether they're observational studies or even as simple as using electronic health records. We take a lot of all these things for granted, but I showed earlier that it is possible to even have biases in those as well. So even in using those data sets, it's important that we're bringing people into the conversation who actually understand experimental design and are making sure that we are getting this well-rounded data sets. And so I'm almost wrapping up here. Interpretable models are huge. It's something that I tended to lean more towards when I was in my PhD. I still do that kind of work now in terms of making sure we're advancing interpretability. And if you cannot use interpretable models in your data sets, there are resources available. So you have LIME, SHAP, Interpret ML Text, which is something I developed while I was at Microsoft. We also have Allen NLP, Interpret, and there's Facebook Captum. There are technologies now, both for NLP, vision, tabular data, that are really trying to push the field in terms of understanding how to understand, in terms of understanding models. And of course, this may be a little bit controversial, but it is possible to use AI or ML to help detect the presence of bias. Yes, they're not neutral. They have their own biases, but we can actually use that to our advantage. If we can understand these models, we can use that to expose some of where the biases are, and we're better able to mitigate. And one of my favorite, and I'm not even biased at all, is Fairlearn, which is developed here by some researchers at Microsoft. And so in conclusion, I just wanted to say that representation matters, and that is in every sense of that word, whether it's in the machine learning scientists who are doing this work, or the clinicians who are attending to patients, or the user-centered designers who are helping us with the studies, or the students who we're teaching, or the people who are part of our studies. Representation matters across the entire spectrum. And if societal biases are not mitigated, communities of color will continue to be left out of these technologies, left out as these technologies are created, and this can only increase the harm that is being done to our society. And so with that, I will say thank you.
Thank you, Ehi. Really great work that you've done and are doing. And yeah, that's a key message. Representation matters. Thanks for emphasizing that.